So it is a pleasure and an honor to lead this session. We're going to speak about 3 topics: pediatric trauma, followed by the Clostridium difficile. I would like to call Dr. Robert Todd Maxson from the Arkansas University. Dr. Maxson, please. Are you in the audience? You here? So he was on the other side. My mistake. So Dr. Maxson was trained at the University of Texas in Galveston, and after that he went to the Arkansas University, where he had the fellowship in pediatric surgery. He's the medical director of the trauma unit of the Arkansas University and a member of the trauma committee. So it is a pleasure to have him today, and he's going to speak about pediatric trauma and child abuse, workup, and recognition.
Thank you. Good afternoon. Buenas tardes. I appreciate so much the program committee's invitation for this. It's a wonderful opportunity, and I appreciate you spending a little bit of time on the pediatric trauma patient. I apologize to the translators. I know it's doubly difficult to translate from Arkansas to English to Spanish, so I'll try to help with that. This is an important problem. I would say this is probably our #1 cause of preventable mortality in the pediatric patient population. And under the age of 1 in the United States, in Arkansas, in our hospital, this is the #1 cause of death is from murder. Homicide in non-accidental trauma is our leading cause of death. And most of the time, there has been a warning sign. There's been a call for help from the family, from a family member. The child's been to the emergency room, and if we could recognize those signs and symptoms, we could prevent this senseless death in all of our trauma centers. Failure to act is not only a criminal offense, but it's sort of a moral and ethical problem for us too that has lifelong consequences for the child. I ask our residents, tell me what you think. The most lethal presenting mechanism is, #1, gunshot wound, #2, high-speed car crash, #3, fell from couch. It is absolutely #3, fell from couch. Now, obviously, it's a nonsensical presenting symptom and not true, but the lethality of it is incredibly high. We treat these things differently, too. If we saw this baby, if we pulled this baby from the wreckage of this car, we would assemble the trauma team and we would address the ABCs in that order. It would be a very orderly, injury-focused resuscitation. If we see this baby come in and the story doesn't make sense and somebody mentions the word non-accidental trauma or abuse, we interestingly change our priorities there. We begin looking first at the social situation. We begin asking how this happened. We sort of cast doubt on the family, and we don't stop and say, this patient has been assaulted. This patient can't advocate for themselves. I must treat this first as an injury and work it up as such. So really what we need is a head-to-toe evaluation and treat it exactly like an injured patient. And there's value to doing this because most of the time there are other injuries. The baby that comes in that we believe is only shaken very, very frequently has other injuries. Those other injuries are often in the chest and abdomen. The magnitude of those injuries is often much higher than it is in a motor vehicle collision for which we see the child. We would work them up completely. Many times the overall injury severity is higher. Many times those thoracic and abdominal injuries require operative intervention. We're in a delayed fashion, so we're well behind the power curve as we begin the evaluation on these children. The most common child that we see is obviously the pre-verbal child under 5 months, oftentimes developmentally delayed or has other chronic medical problems. And I get it. Listen, I have 3 children. They're maddening at times. I absolutely get that they're frustrating, and we see them in family dynamics in which there's not a lot of support or there's not a way to pass that baby off to somebody and take a break for a minute. So under the 5 month is probably our most common. Up to 1 is another break point, and then pre-verbal is probably our third break point. The presentation is fairly classic. The magnitude of the injuries found is disproportionate to the story that's told. The 2-year-old fell on his belly. He fell down while toddling. He fell off of the couch onto a carpeted floor. He fell down 2 steps. These are not really mechanisms of injury that we would expect to impart high energy injuries to the child, and so there's a discrepancy there. There's often a delay. The mother who may know that the child has been abused or mistreated brings the child in during the day while the assailant is not there. They come in by private car rather than by ambulance. Very different than you would expect from an acute injury. The child really does fall down a group of stairs. What's the natural thing? That mother's going to call 911, an ambulance is going to show up, and they're going to come in immediately. This doesn't happen frequently. This doesn't happen with a non-accidental child. Oftentimes the proposed mechanism is physiologically or developmentally implausible. The 4-month-old did not roll off the bed because 4-month-olds don't yet roll. The 2-year-old really didn't throw the truck with enough force to cause a duodenal injury. Those things are just sort of developmentally improbable. So, and the problem with this is that we, the trauma surgeons, we, the injury care team, often get summoned very late. So it's common for these kids to come past our first line of defense, which is the emergency department and the trauma team, and come into the emergency or come into the ICU as a seizure, a febrile seizure, a lethargy, a vomiting, and then the injury is noticed, and again, we are well behind the power curve. So the ability to mobilize your trauma team to anywhere in the hospital to respond to these rapidly is really one of the responsibilities, I think, of any hospital, and particularly of the freestanding children's hospital who sees a lot of these. So the philosophy of management really should be, again, that these are injured patients first, and that the evaluation, resuscitation, and treatment is done in an orderly fashion where we identify the injury. Absolutely, we put the child in a place where no further harm can be done. We nurse them with the family until we can no longer nurse them with the family. We nurse them with the family close to a nursing station or in full view of people. We put them in a video monitored room. We do those things to protect the child, but our first priority is the injury treatment. Next, we're careful about the acquisition of data and information that would help in a forensics evaluation later, so we document bruises. I'm a trauma surgeon. If it's not bleeding, if it's not badly broken, I'm not too worried about the bruises usually. In this case, I'm going to pay particular attention. I'm going to be very careful and purposeful in my description of those injuries. And then I'm going to call and work with my child assessment or child abuse team later to try to help get a good forensics evaluation and help them get to the truth once we've finished the medical evaluation. I believe there is a strong reason to create a protocol here. We all come with biases. I don't believe that family could have done it. I know that family. There's no way that could have happened. This person looks like a family that would have abused their children, and we treat them arbitrarily. We treat them arbitrarily. That's not fair, and it's really not accurate at all. Really not accurate at all. And so, because the consequences of this are so high, the consequences of sending this child out, if you miss that the injuries that they first presented for were from non-accidental trauma, the lethality of that's about 50%. You can't afford to do that. We shouldn't introduce our bias, so we should have a protocol that treats every child the same. At our hospital, at Arkansas Children's Hospital, this is our protocol. And you can put the number anywhere you want. You could put it under 5 months, you'd have a really high yield. You could put it up to 2, and you'd have a little bit lower yield. We've chosen sort of as a threshold about 1 the pre-verbal child, and we've said that any pre-verbal child that comes in with a head injury or a skeletal injury, any child who is developmentally delayed and non-communicative, or who the emergency department physician believes the mechanism could be abused, any of those fall into the pathway. So that's how you get into the pathway. You can be excluded from the pathway if you're in those categories if the injury is witnessed. Essentially, EMS comes and says that car was destroyed. We pulled the kid out of the car. The supervisor at Walmart says we have the video of the kid taking a header out of the shopping cart at Walmart. We can exclude that child. But for the most part, if they don't fall into that, then they start down the pathway. The pathway then ends up being activation of a trauma team for a complete evaluation of an abused patient. That's how we start. We're very good at documenting our injuries, and if there's injuries above the clavicle, we get a head CT with a 3T reconstruction of the skull, because that's been shown to identify injuries that otherwise are missed in usual sagittal CT scanning. We get a coagulation profile because we're going to have to refute at some point a defense attorney's claim that this child has an inborn error of metabolism that causes their easy bruising or bleeding. And then we're going to work up the chest with a chest x-ray and the abdomen with a physical exam, a FAST, and then some screening labs, and I'll come back to those in just a little bit. And we're going to get a skeletal survey looking for other bony injuries. Again, remember, this is somebody who's suffered one injury, can't tell you anything else, and this is how we're going to work them up head to toe. If they've got intracranial injuries, then we get ophthalmologic exam looking at the retinas for hemorrhage, and we get an MRI looking for the magnitude and the type of brain injury that you can't really see on the CT. If the skeletal survey is initially equivocal, we get plain films, dedicated plain films of an area in question, and if we still have question, we'll repeat those images in 5 to 7 days, because often the callus formation is exuberant and very quick, and you'll see something a week later on that body part that you may not have seen on an acute fracture. So that's how we treat the skeletal exam. The pediatric service is consulted if there's comorbidities. Again, it is the 5-month-old with developmental delay or who has a concurrent or concomitant medical problem who ends up being abused frequently, and so we need the help of our pediatric colleagues. But our child abuse assessment team, really forensically trained pediatricians who are good at putting all this together and liaisoning with the legal services and with social services, are invaluable at our hospital. Absolutely invaluable at our hospital. And if you don't have these kind of people in your hospital, but you see these, I would strongly recommend that you create a liaison at a freestanding children's hospital with a service like that. We have telemedicine that's pretty widely used in the state of Arkansas, and if you don't have them in your hospital, you can always call us and look at the pictures with us, talk over the case, and we've gotten an expert, forensically trained pediatrician who can help. So, if the patient's injuries are worked up, found to be not requiring admission, if social services can guarantee that the environment is safe and they've got their investigation underway, then the child can be discharged. If that can't be done, then we're going to admit them to the hospital either for injury first or for protection until the social situation is worked out second. Now, a couple of my friends, David Weston in Houston, and then David Notrika in Summer, who's here, wrote very valuable papers about the importance of the involvement of the trauma service in the admission and oversight of these patients. I think they showed that it decreases the length of stay, it decreases the missed injuries, it decreases morbidity if the injury service is the one that's overseeing their care. And I know that a lot of these, after the first day, are often non-operative, and there's some social situations involved in this, but it still has a great benefit to put these patients on a trauma service. Let's talk for just a second about some very specific injuries. The first one, and probably the most highly lethal injury that we see, is the shaken baby or the intracranial injury. These are often subarachnoid hemorrhages. They often have a lot of diffuse axonal injury associated with them. The outcome is incredibly poor. And if you measure intentional versus unintentional injury, the same injury on the initial CT, that baby with the unintentional injury is going to do much, much worse because of the shearing that you don't really see on the initial film. So we have a very tight protocol that mimics the Traumatic Brain Injury Foundation's guidelines, and we admit them, and we're very, very aggressive with their resuscitation. And we find that in general, the outcome, if given, is much, much better for this patient population than the adult patient population. So there's a value in sort of pushing hard in this patient population. The second injury is that of the occult intra-abdominal injury. So all of you that care for trauma patients have seen this kid that puts the lap belt under his arm and has sort of a pinching of everything in the viscera between the anterior-abdominal wall. Well, the same mechanism occurs for the child who's been abused, except instead of a lap belt, this is typically a fist or a heel of a boot or something such as that, but everything between the anterior abdominal wall and the spine ends up getting pinched and compressed. So now you can appreciate and anticipate what injuries you might see. You're going to see bowel injuries, mesenteric injuries, pancreatic injuries, even aortic injuries as everything's compressed between that and the spine. So a very common injury that we see with non-accidental trauma is this, a mesenteric tear with bleeding into the abdomen, maybe no solid organ injury associated with it on initial CT. I talked earlier about using markers of abdominal injury, and we do a physical exam. We do use the FAST. I know its utility has been questioned, but we find in patients who are in extremis it's very, very helpful. And then we combine those two modalities with laboratory evaluation. Now, if a patient has peritonitis, they go to the operating room. Patient has suspected peritonitis but not extremis, we go get a CT on them. If they don't have those, then we'll use the labs as a marker of occult injury. Probably the most sensitive of those is a urinalysis. Now, this is all a predictive value equation in that one red cell on high power field may have an injury, 1,000 probably has an injury, and there's an algorithm for it somewhere in between. The number that falls out at about a 70% positive predictive value is about 10 red cells per high power field. So 10 red cells on urinalysis per high power field connotes a significant force has been applied to the abdomen. It doesn't necessarily mean that that force has been applied to the genitourinary system, but rather to the abdomen as a whole. The response is that you'll get blood, occult blood in the urine. So 10 red cells per high power field has a high chance, a high enough chance, at least we believe, to warrant going ahead and doing secondary CT scanning. So that's how we use that. For the liver injury, you'll also see red cells in the urine, but you'll also, additionally, you'll see release of the transaminases, the SGOT and SGPT. Now, these have a fairly predictable rate of decline. They decline quickly over about a 24-hour period. And so the kid who comes in, you've seen some work previously that have shown that a kid who comes in from a car wreck that you'd like to use screening labs on to predict who needs a CT scan, those numbers are about 200. Because, again, the nature of the presenting symptom is not always accurate and the time has lapsed, we decrease that number to 80 and 100 for AST and ALT, and we use those as thresholds for doing the CT scan if the initial exam doesn't show peritonitis. And they have a pretty high positive predictive value of having an intra-abdominal injury. Doesn't tell you where, how bad it is, it doesn't correlate with the degree, but it does tell you that there's an injury. Pancreatic injuries are a little bit harder because the initial amylase and lipase is often misleading. But again, the benefit, I guess, the silver lining to this is that if the injury is delayed, then the amylase and lipase do become somewhat predictive. And so in non-accidental trauma, a persistently elevated amylase and lipase does warrant further evaluation. So we'll often see that, and if we see it after the initial CT scan and they continue to rise over the next day, oftentimes we'll go back to further delineate that pancreatic injury with an IV and limited oral contrast just to light up the C loop of the duodenum and get a better definition of that pancreatic injury. The one we dread probably the most is when none of the solid organs are injured. There's this sort of muddy-looking mesentery, and you suspect or believe there might be a mesenteric injury. There's no free air. There's no hard sign to go operate, but you're worried about this. And there's a little bit of free fluid, probably from bleeding. Again, not a hard sign to go to the operating room, but certainly a worrisome finding for a bowel injury or a mesenteric injury. And again, I showed you this earlier. This is probably one of the more common injuries that we see with abdominal physical abuse. We oftentimes will do an IV contrasted and an orally contrasted CT in this group because it will oftentimes light up and show us better delineation of ischemic bowel. We'll sometimes do that late. I get asked also frequently after we've cared for the child, and when I'm speaking to the law enforcement people or the social workers, well, Doc, how do you think this happened? Tell me how this happened. The mom says this, the boyfriend says this, but what do you think happened to it? And I guess my response is that it takes a lot of force to inflict these injuries. And so a couple of things. In an evaluation from San Diego over about a 10-year period, an evaluation from Dallas and Austin, Texas by Nilda Garcia, looked at this and said that bowel injuries in the very young kid, not from a car crash, are typically abuse. Nilda's study said everybody with a duodenal injury was from an abuse mechanism. The San Diego study, about 50% of those. But it's a high enough proportion that if you as the surgeon start on the other end and are operating for a bowel injury in a kid under the age of 2, you should probably be suspecting non-accidental trauma and bring in some help in the evaluation after this. Again, my experience is that these are very high-risk injuries. I get periodically on the stand sometimes, well, Doc, this kid, Mom says he fell down a couple of stairs. Couldn't that have done it? He got CPR on the way in, or he got CPR in the hospital. Couldn't that have done it? And actually the literature is replete with studies that say, no, that's not how it happens. It happens in things, and I'm often said, well, Doc, couldn't it have happened that way? And I have to respond, I don't know whether it could or couldn't. I'm just telling you, in 25 years of pediatric surgery practice, what I see is that these things happen when they fall from great heights of 4 or 5 stories. They're struck by cars. Those are the kind of things I see. So high energy, I don't view that falling down the stairs, and neither does the literature view that falling down the stairs, CPR, 3-year-old threw a toy at him, 4-year-old did taekwondo on him. I don't see that as causing these kinds of injuries. Next question is usually I get, well, Doc, when did this happen? The mom says this kid was fine this morning when she left for work, so it must have been the babysitter. And I think all of us that are surgeons have a really good handle on this because we operate on perforated appendicitis, right? So we know that the kid who's got an ischemic part of the bowel has a very distinct symptomology. They have initial ischemia, and it has localized pain, and then they have vomiting, and then they have nausea, and then they have a white count, and within about 12 hours they have generalized peritonitis, and within about 24 hours they have shock symptoms, and then it just gets worse from there. It doesn't get better and worse, and it doesn't look fine, and then you're in shock. It just doesn't work that way. And so the kid who comes in and we do the laparotomy and we find a belly full of pus and fibrinopurulent exudate all over the abdominal cavity did not look good 6 hours ago. It just doesn't work that way. So keep that in mind. You actually have that knowledge and expertise. You don't have to done a forensics fellowship to use your surgical experience to know those things. So what about delayed perforations? Can't these occur? You showed me a picture of a mesentery that was torn, and can't that bowel go on and die later? And I would say yes, it can, and there is evidence of that. That's very rare, but there is evidence of that. And I think this speaks and confirms the findings of Summer and David, where they said that these patients are best observed on the surgical service, because I think that's the group who's likely to intervene before there's a problem, but absolutely it can be. But those patients that have bowel ischemia, again, every one of us in our surgical training have had the patient with bowel ischemia. They are symptomatic. So again, it wasn't that they were normal this morning, but we're having bowel ischemia enough to perforate the bowel this afternoon, and then we're operating tonight. It just doesn't work that way. They had symptoms during that day as the bowel is ischemic. So in summary, I just sort of like to reiterate those important points in this very vulnerable patient population. These are assaulted patients. They should be worked up as such. They should look exactly the same to your trauma service as the guy who comes in who's drunk from the park that you can't evaluate, that you start working up head to toe. This is a child who's nonverbal, who can't tell you where they hurt. The story is often misleading or not accurate, and so they've got to be worked up in a systematic way. These injuries are very, very lethal. Missing the injury, missing the fact that it could be inflicted by somebody that you're about to send them home to is both legally and ethically wrong. And so it really is our obligation to be involved. I know sometimes we don't want to be, but it really is our obligation. These injuries are not trivial. If you see one, there is likely to be others. It is rarely just a shaken baby with a head injury. There is often other injuries, and the injury severity of those abdominal thoracic injuries are much greater as a group than they are for motor vehicle collision. It didn't occur due to a trivial injury, so the discrepancy of falling down, getting CPR, getting a toy thrown at them, having the 4-year-old jump on them, just is not accurate. At least needs to ring bells, at least needs to put them in a pathway to get a systematic workup. It's very, very rapid, and we've got to be attuned to those patients that slip through our first line of defense and really teach our medical colleagues in the ICU, on the pediatric floor, and in social work to give us a call if we see these. My recommendations are you create a pathway in your hospital. Decrease the variability or the subjectivity in trying to judge a family or a patient. Don't do that. If they've got this injury, they fall into a pathway. It makes it so much easier to respond to both sides. No, ma'am, I'm not doing this because you're a redhead from Arkansas. I'm doing this because we do this for everybody. We do this for everybody. No, ma'am, I know your husband's a judge here in town, but we do this for everybody. It helps get you out of those subjective situations. And then partner with your child advocacy team. If you don't have one at your hospital, marry up with a freestanding children's hospital and do it either by telephone or even better by telemedicine when they can help you evaluate a patient. Those are really good people worth working with. I appreciate the time. I appreciate you letting me talk about this very important topic, and I'll try to answer any questions. Thanks.